antifolate. So therefore, if a patient is on methotrexate, don't give that together. Number 3, don't give it in pregnancy. In men, okay, remember, for women, it's going to be for 3 days. For men, exactly same, give it for 7 days. Okay, 7 days. In the elderly, UTI is a common cause of confusion. Okay, don't forget, guys, UTI, low sodium, hypercalcemia. Okay, so hypercalcemia, a person has high calcium. What is the management? Who knows the management for hypercalcemia? IV fluid, lots of IV fluid. If it doesn't come down, what's next? Good. Bisphosphonate, but only one type. Palmindronate. Yeah, infusion, palmindronate infusion. Good. Now, one thing, guys, one exam thing that they get you, if a patient has positive UTI dipstick, okay, but has no symptoms, don't treat. Okay? If a patient, imagine there's a 40 or just say whatever patient there is, 50-year-old patient, the urine dip is positive, or nitrate positive because has got infection, but he has no symptoms, don't treat. Okay? Acute pyelonephritis. What did we say, guys? Low in pain. Any of this pain? Any low in pain with fever. Acute pyelonephritis. Very, very simple. Common cause again, E. coli. Because why? From infection, UTI, isn't it? Yeah, E. coli. So, very important here. High fever, rigors, vomiting. Highlight this. High fever, rigors, vomiting. Now in here, treatment is going to be IV gentamicin or IV coamoxiclav. You can give either of them. In the exam, they won't give you both. It will be coamoxiclav IV or gentamicin. Okay? If both are given, give coamox, but they won't give you both. It varies from trust guideline to trust guidelines. Okay? For example, in my hospital, they give gentamicin. In Newham, they give coamoxiclav. Okay? Plus gentamicin sometimes. Coamoxi plus gent. But in the exam, go for coamoxiclav. Okay? They won't give you either. If that is not there, go for gent. Now, remember I said, guys, if we have an obstruction that's causing an infection, this is an emergency. What did you have to do? Kidney obstruction causing infection, percutaneous nephrostomy. Very, very important, this line here. You know catheter. Catheter, remember I said to you guys, MS patient, they might require catheter. What do we give them? Not permanent. Intermittent self-catheterization. Very, very important, because catheter, every time you put catheter in, it will cause UTI. It will cause infection. That's why in PLAB 2 exam, there is a station for catheterization. Okay? Because you have to be aseptic. Not aseptic, you have to be the cleanest possible. Yes, aseptic, yes. You have to wear aseptic gloves, clean gloves. They have a drape there. You have to be aseptic yourself. Because you're putting a foreign body that will cause infection regardless how clean you are. Okay? So the more clean you are, the better it is. So it will cause infection. That's why catheter are very, very important. Don't rush it. Take your time. Be aseptic. Don't be a rush doctor, because this will cause infection. You see some doctors just putting it in, sort of, not being sort of clean. This will cause infection. Okay? So 2 to 7% of indwelling catheter acquire bacteria each day. Even with best practice. Can you see? Okay? With best practice, still there is bacteria there. Okay? Now, there is more risk of having UTI, having a catheter in, short-term or long-term. Now, you see, when a person has a catheter in, and you think, do they have an infection? You don't rely on the signs and symptoms. Or I have dysuria, I have frequency. They have a catheter. Okay? These are the things you need to find. Have they got fever? Are they confused? Because they have a high risk factor of infection, and we look for signs of infection, like high fever. Oh, high fever, what's the common cause? Obviously, they have a catheter in. Rule that out first. Okay? So, flank pain, pyelonephritis, right? Okay? Hematuria. Remember, hematuria can be cause of UTI. Okay? And so on. Dysuria, frequent urination. And, okay, so if you have removed the catheter and they have these things, you can think of UTI, obviously. Now, in here, look, very, very simple, guys. This is important. Focus, please, here. Do not do urine dip on catheter patient. Positive has no meaning because bacteria generally anyway colonizes the tube. Okay, so don't do it. Don't send urine culture if no clinical evidence, because positive result will otherwise simply reflect. So if a patient does not need a urine dip, don't do it. If a patient does not have clinical signs and symptoms of UTI or pyelonephritis, has no sepsis, so imagine this patient here has catheter in. The nurse does a urine dip. I don't know why they do a urine dip anyway. Okay, it's positive. Oh, Dr. Amkon, it's positive. It's an infection. If the patient has no signs and symptoms, he's well, don't send it. Why? Because if you send it, it will grow. The lab will say, E. coli, blah, blah, is growing there, this, that. You think, oh, is it an infection? Let's treat it. No, it's not infection. It's already there. You only send it if the patient has signs and symptoms. That makes sense. Okay? Now, guys, 7 days for catheter. 7 days, just like men. UTI in pregnancy. UTI in pregnancy. If the patient in the condition, it's not treated, the patient, so asymptomatic bacteriuria. Patient has no symptom, but they have bacteria in the urine. If you don't treat this, in pregnancy it's different. If it's asymptomatic, but they have bacteria in the urine, but have no symptom. If you don't treat it, they are four times patient are more less, so it should be patient are more likely to have symptomatic UTI, meaning it will lead to symptoms. In other words, you catch it early. But the thing is, guys, so let's say a patient is here, she is pregnant. We find that she's got infection, she's got UTI based on urine dip, but she has no symptoms. Do you start treatment? No. You wait, you send the culture. When the culture is back, you treat it according to the culture bacteria antibiotic sensitivity. Does that make sense? Because she can wait, and it's better to treat it, exact the bacteria, target it very well. Because they're pregnant. You don't want to give antibiotic for no reason. Okay? You'd rather give the best one in one go. Because what if that doesn't work? And you wait for the culture, or this one is resistant, give another antibiotic, cause problems, right? Lower UTI in pregnancy. 7 days. Remember, we don't give trimethoprim. Don't give it in the exam. Nitrofurantoin. Okay? But avoid at term, guys. Avoid at term. Or, remember I said about kidney before. If the GFR is less than 45, avoid this one. Second line, cefalexin. Cefalexin. Out of all of them, yeah? Okay, if all of them are there, I would go for cefalexin. Cefalexin, okay? Trimethoprim, avoid in first trimester, but in the exam, I would avoid it altogether. Okay? Amoxicillin can be used, but only if you can't give cefalexin. You can't give nitrofurantoin. But in the exam, to be honest, I would avoid trimethoprim. I would avoid nitrofurantoin. I would only go for cefalexin. Okay? UTI in children, common cause obviously E. coli, and all of these causes can be cause of UTI, and we need to do investigation. One thing we need to do is that vesico-ureteric reflux can be a cause, and we need to do investigating for this patient. Okay? In here, this chart here, it shows you signs and symptoms of UTI. So if a patient is sort of less than 3 months old, they won't say they have UTI. They're going to have fever. They'll be vomiting, and so on. Okay, it's a chart you can read later on. Now, in here is summarized here. So presentation on child of a UTI depends on age. So if it's an infant, they'll be unwell, poor feeding, vomiting. I mean, it can be anything else. But among the things, rule out UTI. Okay, rule out UTI. Younger child, abdominal fever, dysuria, we all know. Okay, older child, same thing. That's fine. It's a common thing. Now in here, nice guideline for checking sample for urine in a child. Very, very important. So nice guideline says that if there is In a child, if the patient has a fever, okay, it's unexplained, meaning there's no infection from the chest or anything else, or ears, we're not sure. You need to do urine dip, okay? After 24 hours latest, at the latest, okay, you need to do urine dip. Second thing is that, yeah, so that is the main thing you need to know. Patient has a fever, okay, there's no other cause, urine dip. Child has a fever, one thing you need to rule out is UTI. Elderly confusion, rule out UTI. Catch, clean catch. If not possible, then pad should be used. Okay. Management, if less than 3 years old, immediate referral to pediatrician. If 3 months and has a upper UTI, then you give broad spectrum, coamoxicillin or cephalosporin for longer days, 7 to 10. If more than 3 months again, but lower UTI, you give them for 3 days antibiotic. A child who has UTI for the first time, we don't give them prophylactic UTI. It's only recurrent UTI. Give them prophylactic UTI until they have surgery for whatever the underlying cause. Okay. So a child with recurrent UTI, you put them on antibiotic prophylaxis and you investigate, do they have a mechanical problem, underlying structural abnormality predisposing them to UTI. Last one section is going to be nephrotic and nephritic syndrome. Okay, so nephrotic syndrome, guys, these three are very, very important. So nephrotic syndrome. So in here, this patient basically, they have proteinuria, so high amount of protein in the urine. But it is not enough to know protein in the urine. You need to know how much. More than 3 grams in 24 hours. Second thing is that they have hypoalbuminemia, so they have low albumin. Okay, so therefore this causes them to have edema. Does that make sense? These three are very, very important. These three triad: high protein, low albumin, edema. Now, what is immunoglobulin? Okay, what does it do, guys? Antibody fights infection, right? So in nephrotic, in the urine, you lose so much immunoglobulin. So therefore, they have infection. They are increased risk of infection. Okay. They also lose antithrombin 3. Antithrombin 3, basically what that does, it breaks down clots. If you lose that, that means you have a higher risk of clotting. Now, do you understand what I said? Patients who have renal vein thrombosis, common cause is nephrotic, because they lose antithrombin 3, so they are hypercoagulable, they can cause clot in the renal vein. Yeah? So these things are very, very important. Definition: high protein, low albumin causing edema. They are hypercoagulable because of loss of antithrombin 3. This one you don't have to memorize. Let's learn hypercoagulable. That's the reason behind it. Infection because they lose immunoglobulin. The problem is they lose a lot of stuff from the urine. Okay. Now, minimal changes is, in the exam they give you a child with nephrotic syndrome. The answer is going to be minimal changes. If they don't give you any other clues or clenches, then it's going to be a nephrotic syndrome. Minimal changes is, this is the most common nephrotic thing in children. The reason is because, you see, nephrotic, guys, one thing, right? Nephrotic syndrome, they have the sign symptom. You can never diagnose it until you do biopsy. Biopsy is the only way, okay? You don't do ultrasound, don't want to give anything. Biopsy is the only way to find out, okay? So when you look into the light microscope, everything looks normal. Very small, subtle differences. That's why it's called minimal change. Very small change, minimal change. That's why we need to look for the electron microscope to see it. That's why it's called minimal change, because on the light, we just see any small changes. It's called minimal changes. Very important, guys. So this is minimal change disease. It is common in children. Number 2, you need to know, it is very good responsive to steroid. These two are very, very important. Excellent response to steroid. These two, don't forget. Common, nephrotic, excellent steroid. Next one, focal segmental glomerulosclerosis. In here, basically, put down association. HIV. Hepatitis. So they'll give you those sort of history. Patient is HIV, heroin addict, has got hepatitis, and so on. Put down, please, poor response to steroid. Poor response. Highlight this one. Poor responsive to steroid. And this is a very bad condition to have because it progresses to chronic renal failure. This is very bad to have. So this is HIV, heroin, hepatitis. This patient, very bad responsive to steroid, doesn't work. Okay, it's going to lead to chronic renal failure. Okay, this patient need to have renal transplant. Not need to have, they may need to have in the future when it leads to renal failure. Again, note here, focal segmental glomerulosclerosis has a high reoccurrence rate in renal transplant. This one here, membranous glomerulonephritis. Please put down, this is a cause. In here you link it with medication. And some diseases. SLE, goal, penicillamine, these things. Don't learn too much about this, only learn these drugs. Membranoproliferative glomerulonephritis. On here, put down, just highlight, on the biopsy you see a tram-like appearance. Nothing else. Less of them, you just ignore it. Tram-like appearance. Tram-like appearance on the biopsy. Okay. On this one here, membranonephritis, highlight spike and dome on spike and dome. Membranonephritis, spike and dome appearance. And here can you see membranous, basically I went behind on page 3. It's on page 3. Okay. Highlight spike and dome appearance. Okay. So guys, nephrotic, very, very simple. I know it's very, very difficult, but it's very simple. Minimal change disease, common in children, and is very good to steroid. Next one, what's the other one? Focal segmental, HIV, heroin, very bad to steroid, leads to coronary failure. Number 3, other one is medication linked, isn't it? Learn the medication, and then on the microscope, on the you see dome-like appearance, spike and dome. Next one, you learn about the tram-like appearance. That's it. Now, nephritic syndrome, okay, you don't have high protein, okay? So this is a condition in which you have hematuria, that's fine. Uremia, you can have it, you can have edema, but you will not have high protein. Put down no high protein. Remember, protein will not be high. Only it's going to be high in the nephrotic. So this is nephritic. Hematuria, uremia is there, and edema on the face, facial edema. Okay, remember edema is also going to be a nephrotic, but more because of low albumin. In here, hematuria is there. Okay, you don't have protein loss. Protein loss, other one. Very key differentiation. Loss of protein, loss of albumin, loss of immunoglobulin, loss of antithrombin 3. Okay, now this is very important, guys. Yeah, these two. Post-streptococcal glomerulonephritis. Okay, so in here, the person is going to basically, after 7 to 14 days, they have infection of streptococcus infection. And after that, they have hematuria. Colored urine. Very important, guys. Highlight this. Hematuria. So it's going to be in children. All, okay, mainly children, guys. In the exam, a child is going to have infection. Okay, after, very important, 7 to 14. Please highlight 1 to 2 weeks. That's the main differentiation. Now, what is post? Post means after, right? Post-streptococcal, streptococcal is a bacteria, infection. Okay? So after the infection, you have glomerulonephritis. So cola colored, and then you have a history of this infection, and it only has to be 2 weeks. Investigation, very important, anti-streptolysin O titer. Okay, and the complement will be decreased, C3. Now, IgA nephropathy, also called Buerger's disease. This one, young patient in here have an upper respiratory infection, and then they have this condition after 1 to 2 days. So one of them is days, other one is week. Very good. Okay. And this is one of them. It's called rapidly progressive glomerulonephritis. It leads to renal failure quite rapidly. So, HSP, I think we done that in peds, right? Yes. Remember, normal platelets. ITP, low platelets. ITP. ITP is low platelets. Yeah, only low. And this is normal platelets. Okay. And this one can have a bit of your own time. Basically, this is mixed, nephritic and nephrotic. I won't really care too much about it. So have a read. And I think that's the end of nephrology.